Thank you, Simon. I want to thank the organizers for having me. I just realized the meeting is organized by the gynecology section, talking to gastroenterologists. So here I am, a male with a female name. So I fit perfectly this kind of fluid approach to the topic. So in the next 30 minutes, I will try to give you some highlights on the promises and the challenges in precision oncology for GI cancers, but some of these topics really apply to a number of other tissues and diseases. So this cartoon oversimplifies the pathway that goes from the patient and the piece of the tumor to the analysis, to the molecular analysis, the discussion within a molecular board, and then eventually feeding the results back to the clinic and to the patients, trying to inform clinical decisions. Now, this is something that is happening everywhere. In some cases, it happens over the phone between a pathologist and an oncologist about the KRAS testing or the HER2 testing for breast or gastric cancer. In some other institutions, it's a bit more structured, and the sequencing effort is a bit broader, looking at panels or whole genome. But this is the approach. And more importantly, these are the challenges that we face in precision oncology, and it doesn't really matter whether you work in a community hospital or whether you work at Memorial Sloan Kettering. These are the challenges that we all face. And they relate to practicalities of delivering personalized medicine in clinical routine practice, challenges related to the complexity and the heterogeneity of the tumor, and then eventually challenges related to the fact that probably genomic medicine alone is a bit too narrow to inform properly clinical decisions and improve patients' outcomes. So let's start by reviewing those that are the challenges of this approach. Let's start from logistics. Now, a few years ago, we ran a study in our institution. This was coordinated by my colleague, Noreen Starling, and we recruited more than 200 patients with advanced GI cancers in order to test the feasibility of screening these patients for molecular alterations and then eventually allocate these patients to specific clinical trials. We managed to identify about 40% of patients with an actionable alteration, so something that could point us toward a certain treatment. But unfortunately, we managed to recruit very few patients in clinical trials. And I can tell you, we don't lack clinical trials where we are. So what are the problems on the table? Well, the main issue was timing. We had a very high rate of failure in terms of sequencing, and this is because the quality and the quantity of the material that we could obtain from tissue biopsies was often very poor, and it was particularly poor in those patients where we were using biopsy as a starting point, so an upper GI or a rectal biopsy. And the other challenge was dealing not just with colon cancer, but also with hepatobiliary cancers and pancreatic cancers. The other challenge was retrieving the tissue blocks from the referring hospitals. Now, just to give you an example, because you might wonder, where are these blocks coming from? So this is Chelsea. Madonna lives down here, Stamford Bridge. As you can see, it takes about 12 minutes to get from the Chelsea and Westminster to the Royal Marsden. But still, it took us about 6 weeks to retrieve these blocks. This is not just our problem. 10 days ago, a Japanese consortium presented data from 20,000 patients in Japan, and I would say they do things pretty good. It took them about 20 weeks as an average to retrieve blocks from the referring centers to the central center for molecular profiling. So this looks trivial, but is more complicated than it appears. The other challenge that we face is about the complexity of the cancer. These are two identical clinical trials in advanced metastatic gastroesophageal cancer patients. One is an academic study, one is a commercial study, but apart from that, everything is identical. We are targeting metastatic patients with GI cancers. We are targeting an FGFR amplification using the same drug and using what we felt was the same selection criteria. Now, the academic study that was run in our institution was positive. The commercial study was negative. So here we had a 33% response rate. Here, the study was closed for futility after just few patients. And the main challenge is not that we are really good at running trials. The main challenge was, in fact, the selection of patients. So when we went back, my colleagues went back and looked at the way these patients were selected for FGFR amplification in the academic study or the commercial study, the main issue was the heterogeneity of the biomarker we were looking for. So basically, we were selecting patients for the wrong target because we didn't select them properly. So the last challenge is whether we can define an abnormality in a patient and whether that translates into a real clinical benefit for patients. And currently, even in high-volume centers with a number of clinical trials, we can define actionable targets in about 30 to 40% of patients. We can find a trial for these patients in about 5–15% of cases, and often the depth and the duration of the response we see in the clinic is quite limited. Now, in the future, we might be able to overcome some of these hurdles by integrating genomic with other approaches, so broadening the spectrum of the molecular abnormalities that we are looking for, and also hopefully looking for switching for the dogma of one alteration, one drug, to one alteration, multiple drug combinations. And in this scenario, one important consideration is that probably standard molecular pathology alone is not enough to inform clinical decisions and is not enough to inform design of novel trials. And these are two examples that relate to colon cancer. So contrary to what we thought and expected, BRAF inhibitors alone or HER2 inhibitors alone do not work in colon cancer. But if you combine them, and this comes from robust preclinical science that is based on patient-derived material, you end up with clinically meaningful outcome in terms of clinical trials. So it's very important that we do our homeworks properly before we move certain drugs into the clinical arena. So the platform is there, is being used pretty much worldwide, but obviously there are many challenges. So the question is, what can we do to improve this approach? Technology can help. Hypothesis can also help. And today I will give you a snapshot of what is cooking in the field of novel technologies and how they could help to improve patients' management. So tissue biopsies are here to stay. We rely more and more on tissue biopsies. And as I showed you, there are challenges in using tissue biopsies related to logistics and this inability to capture the evolution of the tumor. And that's why we are already implementing, and I'll show you data in a second, we're implementing liquid biopsies, so blood draws, in order to capture the history of the patient, to capture the evolution of the treatment in the clinic. And then there is the new kid on the block, which is the functional biopsy, which is the ability to obtain material from a patient, grow this material in the lab, and eventually test this material for drugs, aiming to inform clinical decisions. I don't think this is the past, present, and future. I think all the three approaches will be the future because they are complementary to each other, but certainly we need to be aware of all the three components. So let's start with the liquid biopsy first. So when we talk about liquid biopsy, it's a very heterogeneous field. There are multiple biofluids that we can test and multiple biomarkers. If we look at biofluids, certainly a number of investigators are looking at the way we can interrogate saliva, pleural effusion, ascites to gain information about screening patients and defining molecular targets. Urine samples are also gaining momentum, and this is largely because clearly if we can sample patients through urine collection, it's much easier than blood. But we're still facing a number of technical limitations in sequencing and analyzing urine metabolites or other biomarkers, and that's why the blood, and mainly plasma, represent, in my opinion, the best option right now. When we look at biomarkers, well, there are plenty of biomarkers. A few years ago, we all got excited about circulating tumor cells. They do have a prognostic role in breast, prostate, and also in colon cancer. However, they're very expensive to test. The yield of CTCs that we can detect in a metastatic patients is still quite low. So really, we can't use them to track the evolution of the tumor through treatment, for example. There are also other biomarkers. I'm still working on these biomarkers myself, but certainly, even though they are quite sensitive, they lack specificity because you can have microRNAs, for example, that get altered due to inflammation or diet, so they're not really robust as a biomarker yet. So cell-free DNA, which is shed by cells, normal and cancer cells, into the blood supply is the way forward. Within that cell-free DNA, we have circulating tumor DNA, which is a small fraction. Anything between 0.1% to 10% of the cell-free DNA is coming from the tumor. And we believe that this is due to apoptotic cells releasing and shedding ctDNA in the circulation. So if we compare head-to-head tissue biopsies with liquid biopsies, obviously it's an easy win for liquid biopsy because patients don't mind having blood taken, they're not invasive, they are relatively cost-effective. I'll show you some data about the cost that say otherwise, so I think we still need to do some work in this department. But obviously, in terms of timing, in terms of capturing evolution of the tumor, and this multi-regional approach, liquid biopsies offer clear advantages over tissue biopsies. And this cartoon summarizes nicely what we can capture using liquid biopsies. We can capture early detection, we can capture the molecular profiling and the diagnosis of the patient, and then we can monitor response and monitor the evolution of the tumor and the treatment, during the treatment in the journey of the patient. During my talk, I will just give you some examples just to trigger some discussion later on about EGFR inhibitors and the role of ctDNA from the metastatic to the adjuvant setting. Now, I will start by talking about metastatic patients, metastatic colorectal cancer patients receiving anti-EGFR treatment. And the concept is very simple. What we do in the clinic, we test all these patients for RAS pathway aberration because if a patient has got a mutation downstream of EGFR, will not benefit from these treatments. So this is as much biology as you need to know to understand the next few minutes. So currently, in clinical practice, what we do, we test patients on archival material. This could be a biopsy or a primary cancer that was resected from the patient a few years before. So the goal of our study was a prospective phase 2 trial, was to compare head-to-head liquid biopsies and solid biopsies and see whether we could come out with a winner. So to do so, we took chemorefractory patients being treated with a single-agent anti-EGFR treatment so that there wouldn't be any bias from chemotherapy. We would obtain biopsies before the treatment, when the patient responded, and then when the patient progressed, and we will also capture liquid biopsies every 4 weeks and imaging. So this is the elephant in the room. I was talking about heterogeneity, and this is a cartoon that highlights and summarizes one of the cases we faced in this trial. As you can tell here, the primary cancer of this patient scored as wild type for KRAS, while 2 different cohorts from 2 different metastases presented metastasis, and in one case, actually 2 metastases in the RAS pathway. So obviously, if you base your decision here, you would define the patient as wild type, and you would offer the treatment. If you screen the patient at this point, then you would consider the patient mutant, so you would avoid such a treatment. And this is relevant because when we pull together all the data and we look at analysis of the RAS pathway before, in the ctDNA before the treatment, we realize that across our trial, 25% of the patients that we consider and we thought were KRAS wild type were in fact mutant for this pathway. And in fact, those patients with a mutation had no benefit whatsoever from the treatment. So our conclusion here is that obviously there are 25% of the patients that we misdiagnose from a molecular point of view because we rely on tissue. When we expanded the analysis to other members of this RAS family, actually it got worse because 45% of the patients, and this is work done by my colleague Marco Gerlinger as well, 45% of these patients in total would have mutation in the pathway that would make them resistant upfront to such a treatment. The other concept that I want to bring here is the ability of liquid biopsy to monitor treatment over time. So you might be familiar with this sort of graph. So this is one of the patients where in gray, the gray bars are the RECIST criteria, is receiving treatment, the tumor got smaller, the CEA, the standard biomarker we use in the clinic, in black becomes negative and stays negative. But when we looked at certain specific subclones in the RAS pathway in the blood of these patients, we could see these clones emerging quite early on during the treatment of this patient. Now, this is very cool from an academic point of view, but from a clinical standpoint, how would you translate this message to your patients? So I have a patient in front of me that is gaining a benefit from the treatment. CT scan looks good, the CEA is negative, the family is negative, and I should tell him that after 2.5 months of treatment, despite achieving a benefit, he's already presenting some red flags that will suggest that he will progress soon. So how can we translate this concept to a broader picture? And this is very important because options in oncology are limited. So if we have a very sensitive biomarker that allows us to detect molecular progression very early on in the treatment of this patient, what we end up doing by changing treatment every time we pick up this molecular progression is squeezing all the available options in 1 year instead of the standard 3 years that we have right now in the clinic. So in order to adopt approaches like drug holidays, rechallenges, adaptive therapy, we need to know exactly how steep is this curve and when is the right timing to change treatment based on this slope. To do so, and I will not bother you with the mathematics, we collated all the data from our trial, all the liquid biopsy data, with imaging data, with CEA data, and starting from the assumption that the population of resistant cells is pre-existing at the beginning of the treatment, we model this data. Now, something that I do understand is this analogy. So we generated an algorithm which is pretty much identical to a weather forecast. So in the same way you can calculate and predict weather based on wind, humidity, and temperature, here you can calculate this window of opportunity and the waiting time to disease progression by knowing the frequency of your driver, the sensitivity of the method that you're using, this might differ between PCR and NGS, and also, very important, the frequency of the blood sampling. And this is a system we are developing. We are building more data on this system because the more data we input in this algorithm, the more accurate this prediction with an average and a standard deviation will become so that we can actually take clinically meaningful decisions based on these observations. Another important topic of liquid biopsy is to translate what we know in the metastatic arena into the adjuvant setting. So this is where the game will be in the next few years. Currently, the oncology approach is very simple. If you have stage 1 and low-risk stage 2 patients after an operation for bowel cancer, they get no chemotherapy. If you have high-risk patients and stage 3 patients, then they would get treated. It's not as simple as it looks because there are about 10-15% of these guys up here that have a very nasty biology and would actually benefit from receiving some chemotherapy after the operation. And there are 60% of these guys down here that achieve no benefit whatsoever by having chemotherapy after an operation. There is also another category, and it's the category of patients with high-risk cancers that, despite chemotherapy, still relapse. So the question that a number of investigators are trying to address is whether we can use the presence of DNA in the blood of a patient after an operation to guide these treatments. So can we overcome the TNM classification or at least complement this classification with ctDNA to inform clinical decisions? So this is a slide that summarizes what's going on. These are observational studies that have been reported so far. The bad news are on the left, the good news are on the right. The bad news are the fact that these are small numbers. And in some cases, these cohorts were quite heterogeneous, so they included patients with stage 1, stage 2, stage 3. The good news is that the signal is quite robust, suggesting that if you have positive ctDNA after an operation, or even worse, after the adjuvant chemotherapy, there is a pretty significant risk of developing a cancer relapse. So the limitations are the small numbers and the fact that they are quite heterogeneous in terms of cohorts. What is quite robust is the signal, is the fact that these analyses survive the test of multivariate analysis with other clinical parameters, and the fact that, above all, if we monitor the trend in ctDNA during the adjuvant chemotherapy, we can actually define those patients that will do well and those patients that are more likely to relapse. Another important message is that obviously, and this is present in some of these studies, we could use this sampling of ctDNA over time as we follow up patients in the clinic to actually pick up relapses. So these are some examples of the ongoing trials. This is an example run at MD Anderson in stage 1 and stage 2 colorectal cancer. Usually we wouldn't give these patients any treatment. In here they are randomizing between standard of care, which is observation, they still capture the blood of these patients, or allocated to the experimental arm where they test for ctDNA, and if the patients are ctDNA positive, they get chemo. This is a landmark trial that is ongoing in Australia. Again, 60% of stage 3 colorectal cancer patients gain no benefit from chemotherapy after an operation. They are randomizing 1,000 patients between standard of care, which is chemotherapy for all these patients, versus a ctDNA-informed approach where if the patient is negative, there is a de-escalation. They either don't get chemo or they get less chemo. If they are ctDNA positive, then they get an escalation of treatment and an intensification of treatment. The last example is in MSI patients. It's a study run at Memorial Sloan Kettering. As I said before, there are patients where despite chemotherapy, there is still a pretty high risk of relapse. In these patients, specifically MSI patients, the investigators are randomizing the patients based on the positivity or negativity of ctDNA, and if the patients are positive for ctDNA, they will go and get immunotherapy as a way to consolidate the results of the chemotherapy. So my personal point of view on the use of ctDNA in this setting, I'm still debating whether we are going in the right direction. Certainly we need more data, and this is because there are strong signals suggesting that we can incorporate ctDNA into the TNM, but the data are not final. We are looking at changes in ctDNA, but the changes in ctDNA might rely and might depend on the type of chemotherapy we are dealing with, because ctDNA comes from apoptotic but also necrotic cells, so the way the treatment affects this process can affect the dynamic and the kinetic of these clones in the blood of patients. The fact that sometimes, in my opinion, having a ctDNA positivity after an operation is not a sign of minimal residual disease, it's a sign of proper metastatic disease, and this is not a semantic consideration. These are patients with stage 1 and 2 colorectal cancer. Most of these patients relapse within 1 year from the operation. I would suggest that these patients were patients that were being monitored because at the MDT before the operation, something popped up, maybe a lung nodule, and when they rescanned the patients, they picked up the progression. And also, of course, there are a lot of doubts of what is the best approach to consolidate chemotherapy, because based on what we know so far, all these approaches are not likely to work in the adjuvant setting. Final point is about the cost, because sequencing blood per patient is anything between 500 and 800 pounds for a single time point. If we start monitoring 3-4 time points per patient, obviously this is going to inflate the cost of the entire operation. For the last few minutes of the talk, I will switch gear and I will look at the functional biopsy, so the ability to obtain material and somehow inform clinical decisions based on what we see in the lab. So recapitulating the patient in a dish. Why are these models so important? Well, I already made a point about building on robust preclinical data in order to inform clinical trials and clinical decisions. One approach to do so is to run co-clinical trials, and the principle is simple. Whoever comes through the door as a patient gets a biopsy, we grow this biopsy, and then we screen this biopsy for multiple drugs, and we try to allocate patients to a specific drug based on what we see in the lab. It's a very sexy approach, but whether it works in the clinic remains to be seen, because based on the currently available methods, either the timing or the cost of the operation doesn't really allow to deliver results in real time. So when the technology of organoids emerged now more than 10 years ago, we and many others thought that maybe we could grow these mini tumors, these mini organs in the lab, and we could use them to bridge this gap. Now, organoids are a very complicated entity that is difficult to summarize in 20 seconds. I would say that we can obtain a number of normal and diseased tissues from a number of organs. Certainly the GI tract is one of the best systems to start working on organoids, and applying a series of growth factors, we can impose a pressure that would allow these organoids to grow as a 3D structure in the lab. And the timing of this operation is in the region of weeks compared to months for animal models. So that's why we thought this could be a good idea. So what we did, we ran observational co-clinical trials. So we had a number of clinical trials where we were testing a number of hypotheses, and we would obtain biopsies from all these patients, mainly were phase 2 trials, to be honest. We would obtain between 6 and 12 cores from metastatic deposits of these patients, and we would compare the parental biopsy with the mini organ that we grew in the lab, initially in terms of genotype and phenotype. And the goal here was to make sure that whatever we were playing with in the lab was in fact mimicking what we obtained from the patient in the first place. And then, of course, we ran drug screenings. The core of the study was this one, was comparing head-to-head what we observed in a blinded fashion in the lab or in the clinic. So is there any correlation? And we needed this information because we wanted to run prospective trial, so we needed to test if this approach would have any predictive value at all. So these are some of the organoids that we obtained from these patients. We have been working because of my interest in gastric, colorectal, and some liver. I missed this is a cholangio organoid. This is one of the best areas to work on organoids because these organoids grow quite rapidly, and this is the comparison between the biopsy and the organoid. I don't have time to show you data about the genotype. I can tell you, and you can read the publication, that there is a pretty much complete analogy between the primary biopsy and the organoid that we can keep in the lab for months. The only example I want to give you about this co-clinical trial without killing your attention is an example of few patients that were treated with chemotherapy for metastatic gastroesophageal cancer. So these are 3 patients. 2 of them, 71 and 49, had either primary or acquired resistance to Paclitaxel, which is a common drug used in the clinic for second-line treatment, and 1 patient, 63, was naive to such a treatment. So what we did, here you got on your left the lab experiments, on your right the clinical observation, is that we compared the dose response of these organoids between the resistant patients and the sensitive patient in the lab. And we obtained the biopsy for patient number 63 from a liver metastasis. As you can see here, the patient went on receiving treatment for about 6 months and then eventually progressed. At the time of progression, we managed to obtain a biopsy from exactly the same metastasis. So we managed to capture with these organoids the evolution of the tumor over treatment. And when you look at the dose response curves here on your left, you realize that the chemo-naive organoids coming from this metastasis are more sensitive than the resistant organoids. Now, we have done a lot of biology to understand why this was the case, but certainly the most relevant piece of information here is that we picked up a statistically significant difference in dose response for clinically relevant concentration of Paclitaxel in the region of 2.5 nanomolar. So if you do a blood draw 2 days after the infusion of Paclitaxel, that's the concentration you find in a real patient. And we have done multiple of these comparisons. So clearly, going back to my original slide, if you have cell lines that struggle in terms of reliability, if you have animal models that struggle in terms of timing and cost, organoids certainly fill this gap quite nicely. There are a number of challenges. They're not the solution to any problem, but certainly could be implemented sometime soon in clinical practice. And this is where the problem is. First of all, we cannot use organoids for everything. Again, as I said, if you're working in the GI space, this is one of the best areas to test organoids. We can establish organoids from head and neck cancer, lung cancer. Working in breast, prostate, and bone metastasis makes the use of organoids very challenging. And the other problem is the timing. As I said before, organoids can grow quite rapidly, but still it takes about 4 or 5 weeks to grow them, bank them, genotype them, and then test them with drugs. So clearly, even though this is much better than what you can do with animal models, is not good enough for metastatic cancer patients. So the way forward is, well, there are multiple ways forward. One is to use microfluidity to reduce the number of cells that you can use for the drug screening and speed up the process. And the other one is to locate this sort of analysis where you have a window of opportunity. So if you're treating gastroesophageal cancer patients with perioperative chemotherapy before and after, that's where you can establish organoids, obtain further organoids, and then maybe change treatment after the operation if the treatment didn't work. Same approach for rectal cancer. Adopting this approach in the chemorefractory setting is going to prove very complicated for patients. The last 2 seconds, I want to give an example of how we are combining liquid and solid biopsies and organoids to make sense of data that otherwise don't make a lot of sense. This is a trial run in our institution. Beautiful curves. This was comparing standard chemotherapy, EOC, with chemotherapy plus anti-EGFR treatment. As you can tell, curves are beautiful. The only downside of this trial is that the experimental arm is below and not above. So why did we get to such negative results? And this is important because 2 other trials were negative, and the community decided to shut down the use of and the combination of chemotherapy and anti-EGFR therapy for metastatic gastroesophageal cancer patients. So there are some data suggesting that if you have an EGFR amplification, you might define a signal. You might identify patients who are likely to benefit from the combination with chemo and anti-EGFR. So we screened a number of samples from this trial, both in terms of tissue biopsies and liquid biopsies. Observation number 1 is that we can detect amplification in the blood of these patients, and these amplifications, in fact, correlate with outcome. But this is not really the main take-home message. The striking observation is that if you have an EGFR amplification, you don't do better by combining the chemotherapy and the EGFR inhibitor. You do worse, which in our opinion didn't make any sense. But if you look at these data for overall survival and progression-free survival, you realize that patients with an amplification receiving the combo did worse. And even patients with 147 copies of the gene still didn't gain any benefit from this combination. So I asked my guys, well, let's buy a number of cell lines with an amplification. Let's try to define why this is such a problem. They came back 20 seconds later and they said there are no cell lines that you can test this hypothesis with. So we relied on organoids, and to cut a very long story short, what we identified as a mechanism is that epirubicin induces this internalization of the EGFR receptor to the nucleus. If you have a diploid cell line, nothing happens. If the cell line is amplified, you get more receptor moving into the nucleus. If you combine epirubicin, one of the chemo backbone that we use in the trial, with cetuximab, the antibody itself will induce the internalization of the receptor, and nuclear EGFR will trigger transcription that will increase proliferation instead of decreasing proliferation. So that's why I'm saying it's so important to combine robust preclinical and clinical data in this sort of forward and reverse translation approach to gain meaningful data for patients. My conclusions. There are a number of challenges on the table to deliver precision oncology. Some of them appear quite stupid, but they're not. Some others are more complicated and relate to the biology of the tumor. I believe that integrating different technology and different hypotheses will overcome these challenges. I believe that combining drugs and combining testing will be the future. As far as liquid biopsies are concerned, certainly they are approaching the clinical use in the metastatic setting, for example, for screening for potential abnormalities in patients. The use of liquid biopsy in the adjuvant space has to be properly validated in observational studies and in randomized trials. In our study, the patient-derived organoids had a 100% negative predictive value and 88% positive predictive value. There are ongoing trials trying to validate these observations. And I believe that combining all these technologies, as I said, will allow to define better strategies to treat patients. Just want to acknowledge members of my lab, all the collaborators across the 2 institutions, the ICR and the Marsden, collaborators in Europe and US, and of course the funding agencies for paying my bills. I'll be delighted to take questions now.